Hello, everyone, and thank you for joining us today. My name is Greg Johnson, along with Don Taffel and Laurie Emery. We're members of the Illuminating Engineering Society, as well as part of the Education Committee for the IES Raleigh section. I'd like to welcome you to our presentation today on behavioral health lighting solutions, concepts, guidelines, and strategies for therapeutic design. Today, we have an exciting webinar lined up for you. Before we get started, I'd just like to cover a few housekeeping items. So at the bottom of your screen, um, you'll see a Q&A section. So feel free to submit questions in the Q&A section during the presentation. And at the end of the presentation, we'll answer as many questions as time permits. And lastly, just a reminder that this is being recorded and it will be archived on our YouTube channel. So you'll be able to view the presentation again at a later time or recommend it to others. And I'll make sure to post a link to the YouTube channel in our chat section. And so now I'd like to pass it along to Don Taffel to introduce Laurie and the presentation.
Hi, everyone. We're so excited to have you guys here, and especially Laurie Emery. We're happy to welcome her. She's an LC and an active member of the IES. Laurie has a healthcare market development management for Visa Lighting. Which is a leading brand for performance of commercial, educational, hospitality, healthcare, and behavioral health facilities. Laurie supports specifiers through training for lighting solutions that enhance healthcare applications and move to improve patient well-being. Laurie continues to leverage her professional lighting experience and design background at Visa Lighting through continual research of modern lighting technology and design trends in the healthcare market. This knowledge allows her to engage with the design professionals to promote evidence-based design that encourages healing in the healthcare environments. So without any further ado, thank you so much, Laurie.
Thank you, Dawn. That was very kind of you. I want to welcome everyone today, and I do encourage people to submit questions that they might have at any time during the presentation. A lot of questions might be answered as we go on, but that's always encouraged because this is a presentation for you to learn. Thank you again for inviting me to present today. I appreciate that. So this has been a pretty popular presentation for me, and I'm glad to tell you that it is AIA and HSW accredited. So make sure if you're an architect to get your information back to Greg so that we can get everything recorded and I can make sure that you get your credit for this show, for this presentation. As we get ready in here, of course, like I mentioned, it's AIA accredited. And HSW credits will also be in there. These are copyrighted materials, so we just ask that you be aware of that. And I don't have a problem sharing the presentation afterwards with anyone that would be interested because there's some pretty nice information in here about resources that you might want to have. So basically, we're talking about behavioral health because this is something that has been evolving several years now. We really want to continue to learn and address treatment for those experiencing mental illness, but especially we're going to focus on the environments that provide a safe space for patients and clinicians alike. The treatment objectives that go beyond symptom control to patient-centered recovery, it has a lot to do with the design choices that are included. And we want to make sure that we understand what is it that we're trying to do to create in these spaces, because this course does provide evidence-based insights on behavioral health. And we want to give a complete overview of safety standards, understanding the considerations for lighting and luminaire design for behavioral health spaces, and talk about some of the successful behavioral health lighting applications for patient-centered care. The learning objectives today are to help recognize the needs of various patient populations in behavioral health because there are several. We want to diminish the stigma of mental health through aesthetic choices and control options. identifying the current safety guidelines and available standards that apply to lighting design for behavioral health, evaluate luminaires and lighting design fixtures that promote safe, therapeutic, patient-centered environments, and how to employ lighting design strategies that take the cellulogenesis into account during the design and application of lighting selections. And we will reference a few real-world samples of successful strategies. So the core topics that we'll be talking about today: getting to patient needs, standards and guidelines, the luminaire design, lighting design, and applications. Factors that determine care or lack of care, different patient populations and their needs, and integration with an existing general medical and healthcare structures is something we'll be getting involved in today. Understanding principles and the published standards, understanding there are no real codes out there, but there are some wonderful guidelines out there, and we'll talk about some of that too. So let's get into the patient needs. What kind of behavioral health settings would we be looking at? What are those populations? How about their diagnosis or co-occurrences? Destigmatization is a huge one that we really want to do. And of course, access to care is important. So let's look around and understand what are the behavioral health settings. Well, there's a lot of different things out there. Hospitals, psychiatric hospitals, residential drug and alcohol facilities, eating disorder and recovery, and psychiatric residential centers, as well as PHP and day programs. And so there's a whole lot of opportunity out there to look at different kinds of facilities, because not everybody is going to need the same offer of care. It just depends on what their diagnosis is, what they're going through. Typically, what we have seen, especially in critical care situations where someone is presenting with either self-harm or a severe reaction, are going to end up usually in a hospital emergency room. If they know what's going on with them, they may be able to go to a different location. But these are a lot of different areas that we need to be aware of. Different folks have different opportunities. And so we want to make sure that we have the availability, which is really the bigger deal right now. So what kind of diagnoses are we looking at? Well, there's actually several. Some people dealing with anxiety disorders, many people dealing with depression. We got ADHD, the autism spectrum, bipolar disorders, borderline personality disorders, eating disorders, obsessive compulsive disorders. I've been told I have that one. Anyways, schizophrenia, addiction, PTSD, and suicidal intent. So, obviously these people a lot of times are dealing with things that are far more advanced. When we look at just the state of North Carolina, and the National Alliance for Mental Illness is a really great place to go look for information. They have stuff on every state that's out there. This particular fact sheet is based on data available from February of 2021, which is probably a big deal because if we think about it, we were really just getting through the pandemic at the time. And so there was a lot going on. But we get into the fact that our adolescents are really affected by this. Our kids aged from 12 to 17, they have a lot of them are dealing with depression. And they're saying that 53.2% did not receive any care in the last year. So that's a high number. And we also know that adults are dealing with this, 356,000 adults in North Carolina. And 44.7% of adults reported that COVID-19 had a negative effect on their mental health. So we know that affected adults and children as well. And we understand that suicide is a really big deal. We need to be aware of it. And I believe that actually September is Suicide Awareness Month. In North Carolina, almost 1,500 lives were lost to suicide. and almost 400,000 had actually had thoughts of suicide. And there really is a shortage of mental health professionals. This is a big problem right now. Of over the 2.5 million people in North Carolina, they live in a community that doesn't even have enough mental health professionals. And 21.1% of adults that report symptoms of anxiety or depression were unable to get needed counseling or therapy. And part of the reason is this because we have to create areas where the professionals as well as the patients are comfortable. If they're not feeling safe or if their environments don't feel healing, it's going to be difficult to find those people. The other thing I want to mention too is there's a lot of things about comorbidity and co-occurrence. The biggest barrier, including therapeutic design, is that a proportion of patients with co-occurrence is perceived as small. But in actuality, 25 to 45% of hospital patients actually have a co-occurring mental health condition. And 68% that are coming in with a mental health condition may also have a medical condition. There's a very strong link between mental illness and substance abuse. Many people diagnosed with substance abuse also have a disorder of mental illness. So the terms dual diagnosis, co-occurrence disorders, and comorbidities are often used interchangeability to describe having more than one condition. So these are things that we want to pay attention to. And we also find out a lot of times that the comorbidities often go unreported. And when we say that, that's why we want to make sure that the places that we're designing and what we're looking at, that these places are therapeutic all the time, all areas of a hospital. And I want to talk about Joint Commission. If you're not familiar with Joint Commission, they are going into the hospitals and into these facilities. They are going to be looking at ligature points above all other environmental risks. They need to identify them. They need to be removed from all areas of a hospital. So if you're not familiar with Joint Commission, I just wanted to put in a little blurb about here. In 1951, the Joint Commission on Accreditation of Hospitals was created by merging the hospital standardization program with similar programs run by the American College of Physicians. So the idea was to create a commission that could do these types of things. Now, if a hospital wants to be accredited, this is a great thing. The mission of the Joint Commission is to basically continuously improve healthcare. And it's for the public in collaboration with other stakeholders. They want to make sure that they're evaluating the healthcare organizations and that they're creating safe environments. This is very important to provide the highest level of quality and care. And this is, again, as I mentioned, not just for patients, but also for their caregivers. And so this accreditation of the hospital is important. So then we start talking about the context of this. What does it mean on the design side? Well, as we've just talked about, access for these types of facilities is really in demand. Do we have enough of these places? Do we have enough beds to cover all of the people that are dealing with these kind of things? We don't. I think we're seeing a huge uptick in design and in mental health hospitals coming in. There's still a lot of research going on to understand how to create these spaces. In the past, we've had some spaces that weren't probably the best kind of design for dealing with mental health patients. And we really need to keep that in mind as we go forward. Unfortunately, a lot of times safety is maybe the primary concern. And we see some of the mental health facilities still taking in and making these designs. These are not very safe environments. And not only that, a patient in an environment like that may feel like they're being watched. They may feel guilt and shame because it's a very hopeless situation, and they're feeling isolated. And I have heard from other people who have been patients in these kind of facilities, and it's not comfortable. And often we say, well, we want to make sure it's really safe, but then we can create an environment that feels like prison. Well, maybe a person is not necessarily needing to feel like they're in prison because they're there to get better. This kind of an atmosphere is certainly not, again, feeling very good for someone who is dealing with a mental health condition. So I want to really focus on therapeutic design. And the built environment really can be used as a form of therapy. So as the design community moves forward trying to create spaces, let's think about this. Therapeutic design principles include autonomy. Patients should have control over their environment to an extent that they can. They should be able to somewhat regulate their surroundings. How about a connection to the outside, access to daylight, views of nature? Because this kind of thing can help make patients feel better and recover. Safety is obviously very important because we want to make sure that they have spaces where they can't do self-harm. And we want to make sure that they're comfortable. Natural materials are good. Biomimicry is something that you might want to think about. Organic shapes and forms and patterns can be used. Noise control, acoustics are important to make sure that we're not hearing, the patients are not hearing what's going on in other spaces. Privacy, we want to make sure patients feel like they have some privacy while they're in one of these locations. And of course, positive distraction can be used. A lot of times positive distractions can help de-escalate and applicate a person who's in crisis rather than restraints. So let's take a look in contrast to what I just showed you in the previous photos. When you're utilizing therapeutic design, well, you can counteract those negative feelings with more positive feelings. If you're bringing you say this is a children's hospital. If you're bringing your child into an environment where they're dealing with something, this is a whole lot better situation than maybe some of the others. And then as you notice in this particular presentation here in this space, they have chosen to go with a staff area that's protected through glass. These things have gone back and forth. I've seen them talk about having open nursing stations rather than enclosed. And so there's a lot of conversation going on whether or not that's a good thing or a bad thing, but at least there is the vision. And so I think every project, they need to kind of look at that. And when we want to look at how the facilities are designed. So we have a facility here, and that's one thing that you might want to think about. This one here was designed with 32 inpatient beds, but it has the ability to expand. So they made sure when they were building this facility that they created an immediate need for the beds that they needed and some of the support spaces, but they also have areas that can be later upfit as the funds become available. So those are things to think about in the design. This particular space has an outpatient clinic as well, and it has some consulting rooms, some research space, and they also connect to two-story outpatient and administrative buildings. So this way they can keep everybody kind of together. And that's a nice way to think. They have spaces such as education rooms, and they have some gyms, and they also have a faith center for people who want to exercise their religious beliefs. Privacy and autonomy that we talked about. You know, this is a space where you might have more adolescent patients, giving them a space that feels a little bit more like their space, having an opportunity to maybe feel some confidentiality and some physical solitude is really important. And again, having some choices potentially about some of the control of their environment. Helping a space feel calm and inviting. Again, we're just trying to help our patients feel comfortable to be in an environment that is healing, a patient that they can feel maybe in the space here, we have these little rooms with a cocoon, like a sleeping area, and it gives them a little cozy space. We have found that the children particularly like to kind of get into corners sometimes. So places are sometimes looked at as how we design it to make sure that the children have a place where they'll feel comfortable. And then as we talked about having a sensory room or a comfort room for that positive distraction. A lot of times these spaces are being used in place of restraints and isolation. If they can take a patient and bring them into a space like this to de-escalate, it's a whole lot less stressful for both the patient and the staff, as well as any family members. So if you can create a space that creates this kind of distraction, it's far better than putting a patient in restraints. Obviously, that does happen at times, but the more that can be reduced, the better. So I want to go over some of the different available standards and guidelines. As I mentioned, there's standards and guidelines. There are no codes associated with behavioral health design. I know I've had people ask me about that, but I want you to see that a lot of research goes into these documents. So we have one from the Center for Healthcare Design. This one's been around a little bit longer. It has a lot of articles in it that talks about control and choice and sensory concerns. The other big one is spatial clarity and comfort and style, because a lot of things have shown that if they feel like they're in an open space or in a more controlled environment, it helps make a big difference. We don't want to have a lot of over sensory types of stimulation, but creating spaces where they feel like they have some control. The VA has done a very good job because they are dealing with a lot of military folks that are coming back with PTSD. But they have some good spaces here where they talk about either inpatient or outpatient design. And these particular documents are quite nice to work with when you are working on these kind of facilities. So what are kind of some of the different things that the VA invests in? What do they talk about? What are things that they feel are important? Well, they do talk about variable levels of light, and it's based on activity and time. We also talk a little bit about lighting for circadian support, which we'll talk a little bit more about. Accent lighting, creating that accent for some art and some features in this space that make it feel a little more inviting. One thing that's very important that people don't want to leave out is exterior accent lighting. If you're in a patient room and you're looking outside of a window space and it's just all dark out there, that can be kind of ominous. We want to know what is out there in that dark space. We don't want it overlit, but we want to make sure that there's some lighting out in that area. That's why it's kind of nice if you can create spaces outside of the patient room areas that maybe have some nature there to help bring in some of that biomimicry and to create a place that feels a little more normal. We want to make sure that we avoid excessive illumination in corridors and exterior walkways, but reduce the dark shadows that can appear to be something unknown, especially for PTSD patients. Let's remove correctional style fixtures. We don't want to use that in a patient bedroom because then they begin to feel like, well, this is not a place I want to be. If we're going to use downlights or anything in a ceiling, we want it flush mounted with a nice trim, tamper resistant hardware, making sure that anything that's in there is not something that can be tampered with. Night lighting definitely is to be provided in patient rooms for safety, and if possible, some kind of a way for them to control that. Maybe a way for staff to control, to look at patients without waking them up is very important. We want to have ceiling lining to be recessed or surface mounted, not suspended in patient activity areas. Maybe they don't have to be quite as crazy strong as some of the fixtures that you would put in a patient space. We'll talk a little bit more about those assessments later. Obviously, we don't want anything with sharp edges. We want anything to be tamper resistant. We want it to be break resistant. And of course, we want to make sure that we're not using pendants or floor lamps or table lamps in those inpatient settings. The program might call for tunable lighting to affect seasonal affective disorder or to support their circadian rhythms. And if there's a possibility to provide controls and sensors, they should be silent in operation. There's also what we call the Behavioral Health Design Guide. Kimberly McMurray has been working on this one along with Mr. Jim Hunt, which is pretty much now retired. Kimberly is a big advocate, obviously does consulting for the behavioral health world, and this document is available online. It's frequently updated. It's kind of a living document that she talks about, and you'll find that FGI actually does consult with her on their guidelines. So these are all things that are available that are constantly being updated and very good resources for you to go look into. Some of you may be familiar with the New York State Office of Mental Health. This is published biannually, and it helps provide guidance for the New York inpatient behavioral health facilities. It has actually kind of grown internationally and nationally to be recognized as a resource to help designers find safe products. I always tell people this book has grown quite a bit in the past 5 to 10 years. But the really unique thing is it covers everything from your Division 1 to Division 26, and specifically talks about windows, door hardware, plumbing fixtures, and lighting products as just part of it. How they typically test products is that they're looking for areas where these products can be used, and they'll basically tell you that they have either typically high-risk areas where these are basically patient rooms, medium-risk areas, and then, of course, low-risk areas where you can probably get away with using pretty much anything. And we'll get into the risk assessment as we go forward. So the main things that New York State looks at, their primary committed criteria is ligature resistance. They want to make sure that things can't be looped or wedged on anything that's mounted in that space. They look for things that could be busted to use for cutting. They want to make sure the furniture, if it can't be jumped on. Tamper resistance, of course, weaponization of any materials that are used on products, contraband storage, of course, and then picket ingestion. The secondary criteria continues with ligature resistance that could be created by a product that is could be damaged. There are some codes and regulations there. Therapeutic environment and appearance, of course, is very important. The constructability of those products, the durability, and then how they're maintained. We're going to more focus on luminaire design right now because we're looking at products that have impact resistance, tamper resistance, ligature resistant in the materials that they're made from. When the products are being tested for impact resistance, we use what we call an IK rating. An IK rating scale measures how much external mechanical force a product, electrical product, in this case, a lighting fixture, can take before it becomes compromised. So in a behavioral health facility, fixtures really need to be able to take this impact without breaking or bending on the outside. Even if an inner lens may start to break, the idea is to prevent anyone from tampering with a broken fixture, wedging something into gaps, to create an anchor point, or using broken pieces to cause harm or gain access to the inner space of the components. So when we're doing these tests, these are what we're looking at for the impact. This is the IK rating that you'll use, and it's based on an IK 10 plus, which that degree of protection is provided, and then by the joules that would be included against it. So understanding how these different the fixtures or these mechanical impacts affect it is what we need to understand, that these products can withstand it, and that's how this testing is taking place. The tamper resistance means that fixture can't be altered or broken into with any kind of implement. They will often use in the testing something like a plastic knife, which could maybe be compromised and taken from another part of the facility into a room. So they want to make sure that that can happen. One thing that does come up when we talk about ligature resistance or tamper resistance is some of the materials that are used. We want to, again, we're trying to make sure that a cord, a rope, a bed sheet, nothing can be looped around any of these types of materials. They even will look at maybe things as minor as dental floss. So you just need to be aware of that. It's 11 pounds is kind of the thing they look at. But one thing I want to talk about too is the materials that we use. We need to make sure that we're using heavy duty polycarbonate. And I will talk about pick resistant caulk. I always say use pick resistant caulk in these applications, not pick proof. Pick proof is almost going to be hard to get into ever. Pick resistant caulk is the recommendation, and tamper resistant screws. Keep in mind that the center pin Torx is kind of the most popular tamper resistant screws used. And one of the things is either the flathead is kind of more useful because it can be flush with the frame. But one thing that was found is there used to be a product, or there still is a product out there that looks like snake eyes. And it was found that a young person in a facility was able to confiscate the dog from the Monopoly game, take it back to his room, and use the little feet from the dog in those little snake eyes and compromise the lighting product. So, you know, they have a lot of time on their hands, so they're actually going to be looking at ways to get into things sometimes if they're really bent on self-harm. We want to make sure that the materials being used are strong, that they are flush mounted as much as possible, and that they are going to handle a lot of abuse. Not only are the materials that are on the outside need to be very, very robust, but also the stuff that you might not see, the stuff behind them, the stuff that's part of the installation. All behavioral health products have very specific installation requirements, and those installation requirements need to be followed because that's very important to make sure that the products cannot be removed from the wall in those spaces. So when we talk about some of the guidelines associated with lighting design to create this environmental safe space and maybe support circadian lighting and having night lights, these are some of the guidelines that we would want to use depending on the actual places that we're looking at. So again, we talked about from the guidelines, we want to have access to daylight and nature and views. Again, keeping that area outside lit at night so that they don't look out into a very dark space. Have a home-like, a non-institutional feel, and creating privacy, autonomy, and access to controls when possible. And so all of these things are going to help create a space that feels more comfortable in a healing environment for the patient. So now I'm going to talk a little bit about risk assessment. These are the kind of standards that are available out there to determine just what do I need to have in my space. So when we look at this particular environmental safety risk assessment, there's 4 levels shown here. There actually is a 5th level, which is typically when you're getting into restraint spaces for a person who has really been compromised, who needs some extra help. But these are the ones we look at. So when we say level 1, 2, 3, and 4, level 1 basically are just the spaces for staff. They're supply closets that they're going to have self-closing doors, places where patients are never going to have access. In level 2, these are highly supervised activity rooms, group rooms, corridors where a patient is going to be escorted, or they're going to be with a bunch of group people who are in therapy. And then we have level 3, maybe there's minimal supervision here because these patients are a little further along and they may be less likely to be in a situation of self-harm, such as day rooms and lounges, and even open nurse stations. And then we get into the level 4. These are the patient rooms and the patient bathrooms. And I want to also mention, when we talk about patient bathrooms, it's not just necessarily the bathroom off of a patient room. There's been many, many incidences of patients that are being helped in spaces that are what we call day spaces, where the patients are actually just there for outpatient. And they may have had a bad day. And so they're pretty much supervised in those spaces until maybe they step into a bathroom on that facility, and maybe that bathroom hasn't been addressed as being a point of issue. A lot of times, if a patient's having a bad day, they may leave a counseling session, go into one of these bathrooms, and find there is absolutely nothing in there that's not ligature resistant, and often find patients that have committed suicide in these particular bathrooms. Keep that in mind as you're doing your design, because you may want to make sure that the bathrooms in these particular facilities have a different level of risk assessment. So if we look at a facility and understanding that environmental risk assessment, take your drawings, take your plans, do the layout, figure out what is the best flow. Are we coming in with into a sally port with a patient that is maybe in crisis? Do they need to go through a special exam area, a treatment space? Do they have to end up in a place where they're so severe that they end up having to be in restraints? This is how you lay out your space. This is how you determine what kind of products are needed through determining this risk assessment. It helps with the flow of the space, how things are designed, and how the staff and the patients interact. So some of the things we talked about, some of the different projects, we want to make sure they're welcoming. We want to make sure that in this particular case, this lobby is designed to convey some of the principles of a model of care, a place of caring, welcoming, healing. And we're using design elements in here, such as natural light. Maybe there's some white noise. We got a really pretty fireplace that's all enclosed. It just kind of makes us feel a little more welcoming for the guests. And maybe if this is a place where you're bringing a patient in, you're going to feel more comfortable in here. We talked about having access to nature and views. Here's another place where we have a very nice area where we have people that may be able to come and have a cup of coffee, sit with their counselors, and potentially be able to meet with patients' family members. Again, it's very nice and it's very open, and it's got some of that biomimicry in there, some of the natural stuff. And so it's just a nice area. And as we mentioned, we want to have variable light levels. We don't want the people to feel like they're in a space where it's just overly bright. And maybe these particular products can be made to create cueing through tunable lighting. creating a space where they feel that they understand the time of day, because there's not a lot of outdoor windows maybe in this space. And so if we can create a space where we have that environment, it makes the patients more comfortable. So these are kind of the lighting levels that we will find in the IES recommendations. Sometimes we find that these are a little bit higher than they want, but in normal, these are pretty good. And as long as we're creating some spaces that can, lighting products that can be dimmed, are changed to help the patient feel more comfortable, that's okay too. And then we talk about different zones, like for group therapy and maybe where someone is writing and taking notes, just to have good light levels. What about interactions with staff members? If you're coming into a space, here you see we have an open nurse station or open area where people are coming in. The deep desks are typically something you might see, where it might be a little bit less likely that somebody can interact with a staff member in a negative way. But we look at these light levels as well, just creating these spaces. And in my experiences doing lighting design for many, many years, we always kind of tried to do our lighting through these zones of lighting up certain things, particularly the tasks and so forth first, and then fill in as necessary. And I'm sure a lot of you have done the same. So I want to touch a little bit of base on circadian lighting. I know that many people have heard plenty about circadian lighting. It's a big deal out there. We're still talking about it. I think it's beginning to get a little momentum because people are paying attention to it more. We know that our 24-hour body clock is not based on total 24 hours, but maybe somewhere a little longer. So that's why entrainment can be so popular and needed. When we talk about it from a standpoint of mental health, we find that a disrupted body clock can actually lead to bigger issues. There's a very critical link between sleep and circadian rhythms, as we know, and psychiatric disorders. If a person is dealing with poor sleep quality, that can lead to depression and other mental health issues. It can also contribute to other healthcare issues. Maybe if they're doing diabetes, or maybe they have liver disease or some cardiovascular problems. Circadian rhythm is very important. So we want to address that in these facilities. Some projects that are out there that you may have seen in the past where circadian lighting has been implied or presented. This is a project that's been around a little while, the Swedish Medical Center in Ballard, where they found that creating this space was it was an enlightened, because they didn't have access to outdoors. And of course, being in the Seattle area, sometimes they get a little more unsunny days than some areas like we do here in North Carolina. But the one thing I want to point out with, if you do want to look into going with a tunable lighting system, is understanding as an interior designer what kind of finishes, what kind of colors are selected, because tunable lighting is going to affect what that stuff looks like. So I always would suggest, if you're looking at going from tunable lighting, which is typically somewhere like anywhere from 26K up to 6K, depending on the schedule, making sure that it's a high color rendering so that it doesn't feel uncomfortable, but it does create this kind of cueing space or to help with circadian rhythm. The other thing is, when we talk about circadian lighting, this is a Danish psychiatric hospital. What they found is by reducing the light at night in the corridor spaces to something that was warmer in color temperature, they found out that they had to administer fewer drugs, and they noticed a reduction in patient outbursts and disturbances as a result of doing what they called a human-centric lighting system. basically tuning lighting to a warmer color temperature and a dimmer output, because it was helping with the patients to get more sleep. And so basically, of the 200 staffer survey, 82 of them did respond. 65% said that the patients slept better. 77% said the patients were more calm. And they had reported fewer nighttime disturbances. So if they were sleeping better, obviously that was helping a lot. And so anything that we can do on a lighting standpoint that helps bring some kind of calmness in a place where we're dealing with psychiatric patients, it's a good thing. Whoop. Night lighting is another thing we want to make sure that we keep up with. Night lighting is something we can apply. The amber night light seems to be like the most favored. I know there's been some comments about using red, but red is probably not the best application for a healthcare environment when you're trying to create some safety in night lighting. Amber seems to be a little bit calmer and a little bit easier to decipher, and people feel more comfortable in it. And we can have it pretty dim and still be effective when people wake up at night. Having that home light design, as we talked about, let's do that whenever we can on these projects. This is a project in Wisconsin where they have different types of facilities. This is the Rogers Silver Lake. They have inpatient, outpatient care. They have applied a lot of the things I've talked to here. Some of them have partial hospitalization programs known as PHP, and some have intensive outpatient programs as well. So there's a lot of things we can do. There's a lot of really unique opportunities out there. We have this beautiful eating recovery center in Boulder. This is in Denver, Colorado, and it actually won an award for being creating spaces that were more comfortable and better outcomes for patients. You know, we want to create spaces that feel good. And what are our lessons learned? What have we learned as we've been looking at all these things? Well, we know that there's a co-occurrence. There's a lot of times when someone has more than one thing they're dealing with. We found that therapeutic design benefits everyone, the patients family members, as well as the clinicians, which is really important. A study of the patient population can determine where that patient needs to get their care. Creating a home light, an autonomy, and providing some kind of control that the patients have is very important, as well as privacy, acoustics, organization of a space is very important as well. Providing daylight, nature, opportunities for socializing, design collaboration among the design professionals. Please don't work in silos. Work together, create spaces that are pretty amazing. Now, this is sort of the end of the presentation, and these are all the references that I used to do this presentation. There's actually about 8 pages of these references. So there's a lot of information out there. I encourage you to look into any of this stuff that you might like to know more about. And thank you. I appreciate your attendance here today. So this is sort of the end of the AIA portion. I just want to talk briefly about some of the Visa products that are out there. We're, of course, very happy to have our gig on the front of the cover when we talk about control. Gig can be controlled by touch, which is a really unique opportunity. We have many, many fixtures that are available now for either use for exam, for general illumination. A lot of our products can be provide tunable. We can do BIOS if that's something you're interested in. A lot of our products, we have introduced BIOS products into these products for use, as well as IP65 ratings and so forth in areas that can be cleaned. Of course, Gig is very popular, our backlit mirror. And actually, we've just introduced a non-lit mirror that can be used in conjunction with a Sanibel. I guess I need to kind of see if we're updated here. We'll be updating these with Architects Plus as these new products are added, as we now also have a downlight that's to be done here shortly. So with that, I can end things here. I have a YouTube video of our showroom. Go to our website, you can see that, and that's kind of the end of things here. So,
Laurie, I just had one question. I learned so much from you every single time because of all the research that you do in compiling everything and making it as current and relevant as possible. But what exactly, can you explain the pica ingestion?
oh, well,
Maybe everybody knows that but me, but that was a new term.
well, actually, I can go back to a slide that kind of talks about that a little bit. Let me go back here. So, pica is an interesting issue. I don't usually spend a whole lot of time on talking about it because it's not one of the more comfortable things to talk about, but we have problems sometimes with people wanting to actually peel things off the wall and try to eat it. It's an issue. I think I have a description of pica in here somewhere. Find it. It might not actually be in the presentation as much as, there it is. So it's basically an eating disorder, and it's characterized by eating items other than food. Okay, so they'll eat paint chips. Sometimes they eat paper. I mean, you find people eating their own hair. I mean, it's just really a big issue. Obviously, things that don't have any nutritional value. So, it's an it's a disorder that sometimes people deal with.
Okay. Well, thank you so much. I appreciate that. And I'm sure if anybody else has any additional questions, they can send them to Greg via email. Also, their AIA numbers if they need certifications and for the AIA and HSW credits. And we just appreciate your time and expertise.
Well, thank you. Was there any other questions by any of the other attendees?
They just wanted a copy of the presentation, and we're getting a lot of thank yous in the chat.
Oh, okay, great.
And great job. I'll give it over to Greg.
Good. Well, I know there's a lot there, and I try to go through it pretty quickly to make sure that we have time. But you know, if like I said, I can provide a PDF presentation to Greg for you guys to distribute for anybody that's interested.
Perfect. And then this presentation will be available on the IAS Raleigh YouTube channel as well, if somebody wants to go back through it. But it'll be helpful because of all the references that you had to actually have a copy of the presentation. So email Greg for that along with anything else.
Excellent. Well, thank you for attending today. I appreciate you all, and thank you for inviting me to present with the Raleigh section today. That was very nice. Thank you.
Yep. Thank you, Laurie. I appreciate your presentation. And thank you all for joining us today. We appreciate your continued membership and for joining us on the call. Again, if you're not a member and you would like to join the IES Raleigh section, you can please visit our website, raleigh.ies.org. And also keep an eye out in your email to sign up for the next Lighthouse educational webinar. And I've put links in the chat. So again, as we mentioned, if you have other questions that you would like to get answered, you can email us at the emails listed in the chat, or if you need a certification, whether for AIA or any other anything else that you would need certification for. And also I've got a link to the YouTube channel in the chat. So thank you again for your time today, and we look forward to seeing you next time. Thanks, and have a great day.
Thanks, Greg.